Very good evening, one and all. What a lovely evening, because it's been, at least for me, it's been a long time to take a moderator role in CCI for various reasons. For the past 4 months, I'm coming back again to moderate this wonderful evening session on behalf of CCI. Sincerely thank, profusely thank CCI Organizing Committee, in particular Krishnanna, Narayan Pradeepa, Ashish, and entire team. Today, my dear friends, please stay tuned to next 1.5 hours for this lovely discussion. We are going to discuss on, in detail, in depth, intricacies of management of diagnosis, management of mesothelioma. Yes, we are well aware it is a rare issue, but having said this, but once we get such a bouncer in our practice, how to tackle it, how to deal with it, we'll be discussing in detail. For this, we have a eminent panelists. I can call each one as a master batsman. First of all, let me call upon my very dear friend, Dr. Vardhan Puri, thoracic surgeon, senior consultant, benign chest and chest onco and robotic thoracic and lung transplant surgeon from Institute of Chest Surgery, Medanta, the Medicity, Gurugram. Welcome, welcome, Harsh.
Thank you, sir. Thanks for the invitation, sir.
I'm sure you are doubly charged for this topic. The reason being, you are just returning from Canada after your fellowship in lung transplantation.
Sir.
Okay, how was the experience there in Canada? It's a
great.
Toronto General Hospital, right?
Wonderful, sir.
I was there for a couple of days.
Yeah.
Them, right?
Yeah.
In transplant. Wow. Fantastic place.
Great.
Next, I would like to call upon Dr. Deepak Muthreja from Nagpur. Another very good friend from Nagpur, MD DNB from respiratory diseases, European diploma in both adult and pediatric respiratory medicine. Reason being, you are just returning from Canada after your fellowship in lung transplant. FCCP USA, EBUS training at Heidelberg, Copenhagen, consultant intervention pulmonologist. I was there for a couple of days. Viveka Hospital, Nagpur.
Yeah.
Welcome, Dr. Deepak.
Thank you so much, sir.
Dr. Ranjani is also on board. Welcome, Dr. Ranjani Chakravarthy, my good friend. We were colleagues at American Oncology Institute almost a decade back, without which we have, I don't even thought that we would have started a successful EBUS program. 10 years back, we have started EBUS program in Hyderabad, one of the forerunners in starting EBUS program in this part of South India. So for which Dr. Ranjani Chakravarthy has played a very key role. And we have worked upon few cases of mesothelioma together as well. And she is a consultant histopathologist and managing director of CPAT Labs, Hyderabad. Welcome, Dr. Ranjani.
Thank you for that very kind introduction, Dr. Vijay. Really looking forward to being part of this program.
Thank you. Thank you for honoring CCI with your presence. And to begin with, we have already 111 logins at this time. Thank you, audience, for your active participation. Please drop in any queries regarding mesothelioma. We'll be happy to discuss, and then let's share the knowledge about mesothelioma. And with this, I'm expecting Dr. Prriya and Dr. Gaurav. There were some login issues. Okay, for both of them, our team, Mr. Puneet and Vinod, are working on those things. And without wasting much time, I would love to call upon Dr. Deepak for his talk on overall view, broad overview on mesothelioma. Dr. Deepak, over to you.
Good evening, all. At the outside, I would like to first thank CCI for giving me this opportunity to talk about mesothelioma, which is like a very important but rare tumor of the pleura. And also, I thank Dr. Vijay for his kind introduction. So, to begin with, mesothelioma, it's a tumor of which is mostly involving the mesothelial cells. If we see the malignant mesothelioma, we find most of the patients have pleural mesothelioma. Then comes peritoneal, which ranges around 4 to 7%. And we have pericardial and testicular and unspecified, which are approximately less than 1% of the mesotheliomas. Incidence. The incidence of mesothelioma is difficult to calculate as there is a vast difference between the worldwide database. There is long latency period because of which the development of symptoms are so late, then sometimes it is very difficult to know its incidence. And in certain countries, they have started asbestos control measures because of which the incidence is falling down. But in certain countries, yes, it is increasing because the exposure is continuously there. Coming to the etiology, 80% of the cases are attributed to the asbestos exposures. Mostly these are builders, construction workers, we have engineers, insulators workers, then family member of these workers. So the person who is involved or who is getting exposed to their clothes or footwear are also at risk of developing mesothelioma. Then we have shipyard workers. Other than asbestos exposure, certain other etiology factors are also responsible, like ionizing radiation. You have the simian virus 40, then BAP1 gene mutation. Then we have the other also minerals which are erionite and zeolites, which also cause this mesothelioma. Now, what about the pathophysiology? How does this mesothelioma occur in humans? So once we are inhaling these asbestos fibers, these enter the visceral pleura and the pleural space. There they have a chronic inflammatory process. This causes DNA damage and there is cytotoxicity. And this leads to development of asbestosis, pleural plaques, and in some cases, mesothelioma. Mostly these patients are elderly. They present with cough, fatigue, weight loss, chest pain, and dyspnea. Once you have a patient who is coming up to you with unilateral pleural effusion, then you suspect that they have asbestos exposure. You have to do a diagnostic workup. Like we have chest X-ray, then CCT thorax with abdomen. Thoracosynthesis, the pleural fluid would be exudative. And in certain patients, the pleural fluid cytology also is suggestive of the malignant cells. Then pleural biopsy, it's a gold standard to do diagnosis of mesothelioma. It can be CT guided, blind, or thoracoscopic. Thoracoscopic pleural biopsies are most preferred and have a highest sensitivity and specificity as compared to blind and CT guided biopsy. Once you have the sample and you have that this is mesothelioma or mesothelial malignancy, you have to see for the different immunohistochemistry pattern of it. So the most common, we have three types of mesotheliomas. One is epithelioid, we have sarcomatoid, and biphasic. Out of this, epithelioid is the most common one, while second is biphasic, third is sarcomatoid. The sarcomatoid type does not exhibit the mesothelial markers. The definitive primary diagnosis requires IHC assessment, as I was telling earlier. In the tissue biopsies, it should have at least 2 mesothelial markers, and That is, we should do 2 mesothelial markers and 2 adenocarcinoma markers. So epithelioid and biphasic mesothelioma requires combination of 2 positives and 2 negative IHC markers. Calcitonin, cytokratins 5/6, D240 and WT1 are the mesothelial markers. The sensitivities of ranging from 70 to 100% in epithelioid and malignant mesotheliomas. Assessment of mesothelin 1,2 in serum and pleural fluid has sensitivity of 60 to 90% and is elevated in the 50% of malignant mesotheliomas. Now, BAP1 mutation and losses are potential predictive markers of the mesothelioma and potential markers for mostly epithelioid subtypes. We have P16CDKN2A homozygous deletion, which is found in 90 to 100% of sarcomatoid and 70% of epithelioid biphasic mesotheliomas. It is linked with poor prognosis. Now, we have researches which are going on to assess whether analyzing both BAP1 and P16INK4A, which is encoded by P16CD, CKD-N2A in samples, whether it increases their specificity and sensitivity. So once we have known that it is mesothelioma, the next important stage is the staging. So we have this TNM classification. This is 8th TNM classification, which is like, which we have T, which is about the primary tumor, then N, regional lymph nodes, and M, which is distant metastasis. This is done so as to know about whether it is surgically treated or not. So coming to this part, first we have done a chest radiography. Then we do this CT thorax with abdomen. In patients who are suitable for surgery and chemotherapy, we do PET scan, or these patients, EBUS or EUSB is needed for the surgical staging. Further, we do chest, abdominal and brain MRI, or laparoscopic or contralateral VATS is necessary, or mediastinoscopy in case we don't have answers on EBUS or EUS. Coming to the treatment part, the surgical treatment would be dealt by, or the talk would be delivered by Dr. Prriya. While I'll give you the overview of the treatment part. This is once you have diagnosed that it is malignant mesothelioma, you see whether minimum biological test, cardiorespiratory evaluation. If patient is suitable for multimodal treatment, including surgery, if it is yes, you do staging, patient allocation, you do multimodal treatment with MCR. MCR is macroscopic complete resection. So if the patient is not suitable, whether this patient is suitable for medical treatment. If yes, you start with chemotherapy with one pattern with permixrate and the best supportive care. Or if the patient is not suitable for this medical treatment, then you have to give only best supportive care, including palliative care or radiotherapy if necessary. And if the asbestos exposure is there, yes, MPM compensation is given to the patient according to the state laws. Different targeted therapy now are available. That target therapy for angiogenesis, that is bevacizumab, nintedanib. Then we have immune target therapy with pembrolizumab and nivolumab. We have proliferative signaling, which is by cetuximab and sixtutunumab. About HIPEC and HIPOC, the Dr. Prriya would be dealing it in more detail with. I thank you so much for patience listening. And I hand over the session to Dr. Vijay again for further proceedings. Thank you so much.
Yes. Dr. Deepak, it was a wonderful, wonderful overview on mesothelioma. Once when we were postgraduates 20 years or 2 decades back, mesothelioma is labeled as a, once it is diagnosed, and we used to feel that the death sentence is written, okay, and the survival rates were back 2 decades back, probably close to 5 months, 6 months only. But whatever you have shared, okay, it looks like there is some promising treatment for mesothelioma management. Thank you. And after that initial technical glitches, Dr. Gaurav Singhal has joined us. I welcome Dr. Gaurav Singhal, consultant pulmonologist, Neelakant Hospital, Haldwani. Welcome, Dr. Gaurav. And now, may I call upon Dr. Prriya?
Thank you, sir. Thanks for the.
Yeah. Welcome, Gaurav. So now may I call upon Dr. Prriya Eshpuniyani, consultant thoracic surgeon at Kumbhala Hill Hospital, Apollo Hospital at Mumbai. First batch of DNB thoracic surgery of the country. Her specialization is, in particular, uniportal VATS. She got trained at Shanghai, China. So she will be speaking on mesothelioma, more to less, where do we stand? Over to Dr. Prriya for your talk.
Good evening, everyone. Thank you for being a part of thank you for being called actually by the Chest Council of India. Mesothelioma is such an important topic, and I want to thank Dr. Deepak for enlightening us on the causes and the routine management of mesothelioma. I would discuss in short about the surgical aspects of mesothelioma, from where did we start and from where we are. Mesothelioma is more to less, just like in breast surgery, very contradictory, but that is a very similar concept, that we have gone from more to less. Just revising what Dr. Deepak has already mentioned, diagnosis, we have the chest X-ray initially, we have the pleural effusion tapping, we have a CT scan of the thorax and MRI. Sometimes we have a PET CT scan. In some situations, we are not able to get a biopsy straightforward, so the patient has to undergo a diagnostic thoracoscopy with biopsy. This is how a malignant pleural mesothelioma appears on a CT thorax. These are the red bars are measuring the thickness of the pleural disease. So basically, if you can see, it is a pleural disease involving the parietal, the mediastinal, the visceral pleura all around, including the diaphragm. The pleural thickening is measured by the red bars, and more or less, unless it's an advanced disease, the lung is not infiltrated. An MRI chest is routinely done for evaluating the chest wall involvement to decide whether it's a resectable disease or not, and what is the extent of resection to achieve complete macroscopic resection. So MRI chest is not always needed. It is needed only if we are contemplating a major chest wall resection along with a pleurectomy. A PET CT scan is always done to see for the metastatic status of the disease, more so rather than the local extent, for which a CECT or an MRI is sufficient. A thoracoscopy is routinely indicated if in any patient without the precise diagnosis. So basically we do a CT guided biopsy or some markers, but if the tissue we get is not sufficient, then, or if patient has a persistent effusion, we do a VATS, we do a diagnostic thoracoscopy, we take biopsy, we do a frozen section on it to confirm the adequacy of the sample, if not the final pathology. And remember, if you are suspecting a mesothelioma, never ever do a pleurodesis, because then the surgical treatment later on becomes hell of a problem. Mesothelioma is staged in very simple technique in 4 stages. Stage 1, it is localized in the pleura. Stage 2, it has spread to a lung and lymph nodes. That is, it's infiltrating the lung. Stage 3 is extensive, spreading to the lungs, chest wall, abdomen, and the chest cavity. And stage 4, it is metastasized. So it follows the TNM staging as lung. And I'm sure that is something which everyone has already gone through. So coming to the directly to the surgical aspect, it has evolved through the years. And yet at the end of everything, radical surgery remains a controversial issue. We have not been able to yet accept a single universal surgical therapy in view of the morbidity and the mortality associated with it. Numerous studies have been done, but none of them are randomized. So inevitably, if a patient is younger and fitter, in an earlier stage, we try to give them a surgical option. But if a same patient is elderly with less fitness, we try to avoid it. The surgery for malignant pleural mesothelioma is to achieve complete macroscopic resection. So now, since the disease pathology is pleural and it is surrounding the entire chest wall, mediastinum, lungs, it has been accepted very clearly that clear microscopic margins cannot be achieved. So anything which is able to get a complete macroscopic resection is what has been accepted for mesothelioma. And normally in all the patients, we do require a multimodality form of treatment in form of chemotherapy, surgery, plus minus radiation. So to define what are the different kinds of surgeries we have, the Staging and the Prognostic Factors Committee of the International Association for Study of Lung Cancer has formulated some definitions. The first one is extrapleural pneumonectomy, which is en bloc resection of the parietal pleura, pericardium, diaphragm, lung, and the visceral pleura. An extended pleurectomy or decortication is parietal and visceral pleurectomy with the goal of CMR with resection of diaphragm and or pericardium as required. The lesser of the two evils are the pleurectomy, in which only the pleura is removed without any resection of diaphragm and pericardium, or else only parietal pleurectomy, in which only the partial removal of parietal pleura is done, but we do leave a gross tumor behind. That is when we have already assumed decided the patient is inoperable. This is an extrapleural pneumonectomy. So to see that the entire lung has been removed, the pericardium has been removed, a part of the pericardium, the small pieces of diaphragm has been removed. So the entire thing removed in toto is extrapleural pneumonectomy. And here when we take care not to enter the pleura at any point so that we don't disturb the disease process except at the hilum wherein we do the vessel and the bronchus transaction. These are the photographic pictures, intra pictures of extended pleurectomy with diaphragm resection with reconstruction, wherein we have saved the entire lung. The diaphragm has been removed. The diaphragm has been replaced, reconstructed with tensor fascial lata. And this is the specimen of the entire pleura in one piece. So the tips and tricks to remember is that surgery should be dedicated to select patients with only good performance status and with epithelioid or mixed histology, not sarcomatoid, and only if you can achieve a complete gross cytoreduction. It is not recommended for stage 4 or sarcomatoid histology. If there is an N2 disease or a mixed histology, then it should be indicated only in high volume centers, or if you have you are a part of a clinical trial. Pleurodesis and debulking, decortication are palliative surgical procedures. They are used to limit repeated pleural effusions and also, of course, to relieve pain, because the parietal pleura itself is the one which causes the maximum pain. VATS has a very good role in palliative role, but it is not yet accepted to perform the entire extrapleural decortication. Surgery should be dismissed if the macroscopic complete section is not possible, unless it can be removed with a minimal impact on morbidity and advantage of the postoperative management. So in a study by Verma et al. In 2018, they saw that out of the 4,207 patients operated, 68% were epithelioid. And they showed to have the highest median overall survival, followed by a mixed histology and least by the sarcomatoid pathology. Also, surgery was associated with a significantly improved overall survival for the epithelioid malignancy, followed by biphasic, but not for sarcomatoid. So on multivariate analysis, it was seen that the factors predictive of poorer survival included advanced age, male gender, urban residents, treatment at community centers, and T4N2 disease. The prognostic factors for deciding whether the patient can or is either a good candidate for surgery or not is by the EORTC criteria, wherein a poor performance status, a high WBC count, histological diagnosis of mesothelioma, male gender, and the sarcomatoid pathology are the factors which are normally seen to be for the poor prognosis. The latest in the market is HITOC, that is hyperthermic intrathoracic chemotherapy. So as we know that HIPEC, hyperthermic intraperitoneal chemotherapy for primary peritoneal malignancy, then appendiceal malignancy came out to be for ovarian. Now, since last decade or so, we are concentrating on effect of HITOC on the malignant pleural mesothelioma. So it is something which is not yet widely accepted, but it is taking part. It is being included more and more in trials. A presentation, a systematic review and meta-analysis published in OncoTarget in 2017 by Zhao et al. Showed that patients who received HITOC had significantly longer median survival length compared to the patients without HITOC. And in addition, it was as a palliative therapy also, HITOC was favored in terms of recurrence-free interval. So yet studies are yet to come. We really need to have more of RCTs on it. We still don't have. But as yet, it is shown to have some importance, some betterment in the treatment. The thing to remember here is that anyone who performs HITOC should be someone who has a very good ICU backup, high volume center dealing with mesotheliomas with or without HITOC. Simply because HITOC is just an addition of 1 hour in the procedure, but it takes a lot of understanding in the physiology behind it, and the post-operative recovery of the patient depends a lot on how the patient is handled in the post-operative period. Routinely, a single agent like cisplatin or a combination of cisplatin plus mitomycin is used. It is dose dependent, and a medical oncology team has to be intensely involved in the treatment of HITOC. So our center has this data is under purview of publication. So I have put only very limited data here. But 2014 to 2021, we have a total number of patients operated for mesothelioma 14, of which 10 were males, 4 females. And the median age of the patients was 56, with the eldest being 71. All patients received neoadjuvant chemotherapy. Of these patients, 6 underwent HITOC in addition to the primary surgery. What we did see was the extrapleural pneumonectomy had increased perioperative morbidity and increased length of hospital stay. In the short-term follow-up, till last 5 to 7 years, we have found equal, I would say, acceptable survival as yet in the short term of extrapleural pneumonectomy versus extended pleurectomy. So we have now shifted from pneumonectomy to extended pleurectomy with diaphragm and pericardium in most of our patients. We have started using facial atta as the biological mesh instead of Gore-Tex mesh, a dual mesh. We have found it to have less infective complications than a Gore-Tex. This is for the resection of diaphragm. And in HITOC 2, our short-term results indicate a similar perioperative outcomes, and long-term survival results are awaited and they are ongoing. Mesothelioma needs more numbers and longer follow-up to evaluate long-term results. But 14 in last 6 years have been quite well, and we are hoping to get more numbers in the future. So in a very small gist, I would like to say that extrapleural pneumonectomy is now going out of the picture in most of the cases, unless there's a lot of infiltration of the lung. If possible, an extended pleurectomy with diaphragm resection with reconstruction and pericardial excision does a good gives a good outcome to the patient, a favorable outcome to the patient. It's always a multimodality treatment and requires a chemotherapy followed by surgery, and most of the cases do require a follow-up with a chemo or a radiation. And I guess mesothelioma is not a disease which was in the past that it's a death sentence. Just like lung cancer has changed, mesothelioma too is changing for the better, and we are hoping to see better and better results in the years to come. HITOC is promising and we are hoping for good results. Thank you.
Thank you, Dr. Prriya, for such an enlightening talk. You made us, all the pulmonologists, understand the very basic things like what is EPP, what is decortication, what is extended decortication. All this terminology was really new. And thank you, one and all. My dear audience, please do send the questions, whatever you have, whatever regarding mesothelioma, please share in the link provided. So we'll be happy to take all your questions today. Coming to Gaurav. Hello, Gaurav. Gaurav. Yeah. Here is a question which asks, okay, what are the various symptoms and signs that you come across in mesothelioma patient? Basically, when we look these patients, they have a common presentation, probably weight loss, there may be pleural effusion, there may be recurrent pleural effusion. What are your suggestions for the audience so that when to suspect mesothelioma, what are the common symptoms that it presents?
So the patient classically presents with all the symptoms that are similar to other chest diseases. And so it is very difficult to diagnose mesothelioma, and absolutely because of the rarity, you need to have a very high index of suspicion, and you need to be very aggressive if you have any history which is suggestive of an asbestos exposure, so that you can find these patients early when the disease is localized and not spread. The classical symptoms by which patient presents are chest discomfort, the chest pain or a pleuritic chest pain. Sometimes it can also be a non-pleuritic chest pain, easy fatigability, fever, sweats, weight loss. And these are so commonly the complaints of other chest diseases that we need to have a very high index of suspicion to reach an early diagnosis of mesothelioma. Need to go for an early thoracoscopic biopsies to really form a diagnosis and give patient a chance for the treatment. Thank you, sir.
So wonderful. Okay, you nailed the very important point. Is very important to have high index of suspicion when you come across any pleural malignancy. And I would request now Dr. Deepak to add anything to whatever Gaurav said, or is that fine?
So, as rightly mentioned by Dr. Gaurav, that you need to have very high index of suspicion. See, as we are in a TB endemic country, most of the patients who come to us are already put on AKT. Sometimes they have a little bit of a partial response to AKT as well. So once we are seeing that the patient is not having response even after 1 month of AKT, or the patient has come up to us with a recurrent effusion, instead of this, we should actually, instead of continuing the AKT, we should try to go for a thoracoscopic pleural biopsy, which I think is now practiced by most of our pulmonologists, and many courses are also available for them to go and learn this simple procedure.
Right.
So I would like to
raise another important point. 1 minute, Dr. Gaurav.
Yeah,
it's a very important point that without conclusion, my dear friends, do not add anti-tubercular therapy without having a proper diagnosis. Unless you have a confirmed diagnosis, don't even rely on ADA, because there are false positive ADA as well. If your pleural fluid turns positive for gene expert, then probably you can convincingly start anti-tubercular therapy. If ADA is low and your gene expert TB is negative, and you are dealing with a exudative pleural effusion, lymphocyte predominant, malignant cytology vis-a-vis, no atypical cells, they may comment. So in such scenario, my dear friends, so the take-home point here for this is keep a high index of suspicion to diagnose mesothelioma. Unless you suspect, you cannot never diagnose mesothelioma. You may treat it as a pleural adenocarcinoma or something else. So that's very important. And over to Dr. Ranjani. Dr. Ranjani, are you there?
Yes, please.
Yeah, hi. What is the overall etiopathogens pathogenesis of malignant pleural mesothelioma? How often you suspect in your practice? How often it turns positive?
Strangely, the incidence doesn't seem to be very high. In UK, where I did practice for a very long time, obviously we had a very high burden of cases, and we used to routinely test for asbestos bodies. But here the incidence isn't that high. Principally, as we all know, asbestos exposure is the main factor incriminated in most cases of mesothelioma. I think the earlier presentation has given a very succinct description of the etiopathogenesis as well. So principally long-term exposure to asbestos, which itself is carcinogenic, principally long, thin fibers, particular subtypes, particularly zeolite. So these cause chronic pleural irritation with free radical oxygen release, and which explains a long latency period. Usually it takes about 20 to 40 years of exposure to asbestos to develop mesothelioma. Other factors may be in younger patients, in women particularly, a history of breast cancer is an important risk factor, and exposure to ionizing radiation. There is some controversy about SV40, simian virus 40, being incriminated. Most studies, PCR-related studies, have not shown any role for the virus.
Thank you. Thanks for brilliant summary, Dr. Ranjani. And now I would like to call upon Dr. Deepak again. When eliciting history, okay, what are the key points that you will ask in the given patient when you are suspecting a pleural malignancy, particularly of mesothelioma?
So firstly, the occupation of the patient, which is utmost important. So in India also, as it was rightly mentioned by Dr. Rajni, that the incidence is lower, but in certain parts of India, like if you go towards the west part where Gujarat, if you go there, many ship-breaking yards. The people working there come up with a unilateral pleural effusion, and when I was doing residency there, I saw many patients of mesothelioma. So the most important is the occupation history, where you need to know the how much the patient is exposed to that particular dust, and secondly also the bystanders or the relatives of these workers. Sometimes they are exposed to the clothes and which contains these particles, and also the shoes which are carrying these particles home. So even if a lady who is not working in an asbestos environment coming to you with a unilateral effusion, if the husband is working in any kind of asbestos exposure like builders, or is working as a construction worker, or in insulators factory, or in a shipbreaking yard, one should have a high index of suspicion for the malignant mesothelioma.
Thank you, Dr. Deepak. And Dr. Gaurav, you want to add anything? You're muted. Please unmute yourself, Dr. Gaurav.
Just I wanted to just add one thing. The initial part, the difficulty with mesothelioma is, as we have a rapid filling in adenocarcinomas in lung, there is not a rapid filling in mesothelioma. So sometimes we are mistakenly taking the treatment for tuberculosis, as you rightly said, that never treat the patient empirically, always do a biopsy or confirm it with a gene expert or a staining before starting. That is what I wanted to add at that point of time.
In terms of symptoms, you want to particularly high-risk groups, as Dr. Gaurav, Dr. Deepak mentioned very clearly, these persons who work in shipyards and all those things.
Yes, some mining, shipyards, paper millings, the people who work with ceramics. History is the most important thing, and after history taking, the symptoms are classical for any chest diseases. But environmental exposure, and not only the environmental exposure, the relatives of the patients who are exposed to the environmental exposure, that can also lead to this. So the history of the family person sometimes is also required to make a diagnosis.
Right. Another important thing which I want to bring it to notice and then add to whatever Gaurav and Dr. Deepak spoke is, whenever you are dealing with a malignant pleural effusion, if you encountered intercostal narrowing, my dear friends, there are two things which you must look into. One thing, either lung entrapment, or the second important thing is, in such cases, it is very, very likely that this patient, the chances, the probability of turning into mesothelioma when you are encountering with a intercostal narrowing is very, very high. And coming to again Deepak, is it a death sentence to have a malignant pleural mesothelioma? As soon as you diagnose mesothelioma, can it possible to clinically prognosticate, and if at all, on what parameters you prognosticate the family? Because it is ultimately pulmonologist duty to refer to the oncology or multidisciplinary team meetings.
Yeah. So actually, if you ask me that in earlier days, since the life expectancy is between 18 to 31 months in previously reported literature, so many times we tend to tell patient that this is what is there, and you need to understand the prognosis, and we like to give that sentence. It was given very in earlier stages, but now there are patients, and with certain novel modalities of treatment, certain reports are there which are showing that mesothelioma patients have been living for more than 5 years of age. So, and there are certain prognostic factors, like one is that URTC index, which was mentioned by Dr. Prriya very well, that is performance status, then high WBC count, then there is the histology, which is like if it is sarcomatoid subtype, it is associated with a poor prognostic factor. Then we have a MWGS score, which is ranging from 0 to 10, which includes age, histology, then necrotic count, then mitotic cell count, then nuclear urticaria, how many number of nuclear urticaria are present there in the histopathology, then BAP1 expression. So these are certain prognostic factors which are related with the disease, and histologically the sarcomatoid has a poor prognostic factor.
Right. Thank you, Dr. Deepak. Yes, I am well aware that I'm keeping my surgeons off the discussion for the time being. Another 10 minutes will come back to you, my dear surgical colleagues. And I would love to take inputs from what are the various radiological pictures from Dr. Gaurav. And there is some saying at postgraduate level, as soon as you see a pleural plaque, suspect mesothelioma, whether it is benign or malignant mesothelioma or something. Is that true? Over to Dr. Gaurav. Gaurav, are you there? Deepak, possible to take this question?
So there's some disturbance.
Yeah.
So there is some disturbance in the. Hello.
Yeah, Dr. Gaurav, please.
Yeah. Sir, please, can you repeat the question, sir, please?
The question is, what are the various radiological findings based on which that you suspect mesothelioma? Maybe ultrasound, maybe CT, maybe MRI, whatever it is. There is some notion.
So first of all, we'll start with the chest X-ray.
Yep. And
that shows the obliteration of the diaphragm, sometimes the obliteration of the costophrenic angle, of course. There is nodular thickening of the pleura that can be visualized sometimes. Then the very important point that you stressed was the decreased size of the involved chest that you have already mentioned. Then there is sometimes sheet-like encasement of the pleura, and the combination of these findings can be there. Then entrapped lung and loculated effusions can be seen in more than 50% of these patients. So these are the mainly X-ray findings that you see in them. As far as the going ahead with a computed topography, which will give you a detailed picture of the patient, and also will tell you whether what is the stage of the patient, whether the disease is spread to the contralateral lung or not, whether whether the disease is spread outside the lung or not, then most of the cases, the CT will give you the answer and PET will not be required. But if you have a doubt regarding the chest wall involvement, then you can go ahead with an MRI scan. As far as PET scanning is concerned, we need to do if you think that there is no extra pulmonary spread. If because when you do a CT of the thorax, you always cover the upper part of the abdomen, which most likely shows whether the malignancy has spread below the diaphragms. So, but even after that, if you are not sure, then you can go ahead with a PET scan to confirm about that. As far as the role of ultrasound is concerned, in patients, you need to put in a pigtail catheter, you need to put in a IPC for a long-term pleural effusion for palliative. There you can go for an ultrasound thorax.
Thank you, Dr. Gaurav. Another important question which I have asked you is, generally postgraduates and then medicos, they feel that if there is a pleural plaque
Yes,
in
sir.
India, okay, pleural plaques can be because of improperly managed tuberculosis as well.
Okay,
So, pleural thickening because of tuberculosis. So, on the token, what is your take? If there is a pleural plaque, do we need to suspect always mesothelioma, or what is your take?
Am I audible, sir?
Your signal strength is poor. Probably that is the reason you are not
Yes, sir.
tracking.
Absolutely. So, there are no substantiative studies which prove that plaques develop into malignancies, that the patients who have pleural plaques have got high chances of developing malignant mesothelioma later on. So, all these patients of pleural plaques need not be followed for the development of malignant mesothelioma, and we will be working up if we follow all these pleural plaques for the development of malignancies. So I think pleural plaques are what we see so often in tuberculosis, and we need not follow them for the development of malignancies.
Thank you so much. And here quickly, I'll take the input from Dr. Harsh.
Sure.
Yeah, Harsh, hi. So even if there is a PET negative, my boss used to tell me, okay, even if it is PET negative in the abdomen, so surgeons prefer to do a diagnostic peritoneal biopsies at various points. What is your take on it?
Sir, first 4 points which were discussed, I'll just like to. One, the incidence of mesothelioma is going to increase in India tremendously in next 20 years because whole of the asbestos industry is now being shifted to China and India. We are buying asbestos, second most biggest importer of asbestos from Russia. So this incidence is going to increase tremendously in next few years. Second point was that when you are seeing a patient of pleural thickening with a CT scan in your chamber, if the pain is disproportionately higher than the symptoms, than the signs in the chest X-ray or the CT scan you are seeing, always suspect that the patient is having mesothelioma. That is the second point. Third, if the thickening is nodular and it's not smooth split pleura sign, always suspect mesothelioma in that patient. And the other thing is the question you asked. In these kind of patients who are high risk group, as told by Dr. Gaurav and Dr. Deepak Muthreja, we always go for a PET scan. And to be very, it's very common finding that these are PET positive scans. There is a lot of nodular thickening. The striking point in PET scans is if the mediastinal pleura is having these thick nodules, always suspect that patient is having a mesothelioma. Go for a VATS biopsy or a open biopsy. If you are not equipped with VATS, you can just direct your biopsy through based on your PET findings. Go directly to the point, take a big chunk because the pathologist is going to screw you if the tissue is not enough. These CT guided FNACs and stuff doesn't work in mesothelioma. Go for a big chunk. take a big chunk. Only remember, when you are taking a biopsy in mesothelioma, the incision you make should be synonymous with the incision you are going to make in the final treatment of the patient if you are going to do an extrapleural pneumonectomy or a pleural decortication.
Fantastic points. Fantastic points. And you haven't touched about the peritoneal. Do you take peritoneal biopsy? Blind peritoneal laparoscopic peritoneal biopsy, even if it is PET negative, to stage it? No.
No, sir. No.
Oh, fantastic. Right. So, Dr. Prriya, you want to add anything to whatever Hesh said?
Dr. Vijay, I have a couple of points to make.
Please, Dr. Ranjani.
Yeah. Dr. Harsh, thank you for reiterating that point. We do need full thickness biopsies. Principally, we diagnose mesothelioma on biopsy tissue, small biopsy tissue, by assessing adipose tissue or adjacent lung invasion. So even if we don't get lung, we definitely need deeper adipose tissue. This is because even reactive mesothelial proliferation, particularly in our country and particularly with tuberculosis, can look very atypical. So it's only when we see that the mesothelial cells are going into the adipose tissue, we can make a diagnosis on histology of mesothelioma, which is why we need those full thickness biopsies.
Yes.
Thank you. And another important point which I want to add here is pulmonologists who are relatively less experienced with thoracoscopic or medical thoracoscopic pleural biopsy kindly refrain from taking biopsies in such a case, because it is very difficult. When we are trying to dissect the pleura, you will feel very hard as if you are dissecting a rock-like structure. So that's why. So try to refrain, because you cannot do justice with your less experience of taking or giving very good biopsies to the histopathologist. So dear friends, when you are suspecting mesothelioma, if you are experienced, please go ahead and take a biopsy, thoracoscopic biopsy. Otherwise, hand over the case to thoracic surgeons. They will do much better job. And Dr.
Can I just interrupt for a minute, Dr. Vijay?
Yeah, please. I have asked you.
Yeah,
but,
so one more thing, just one more thing is that whenever we do a thoracoscopic biopsy, we always prefer to have a frozen section, not for the diagnosis, but for the adequacy. As Dr. Harsh also has said, we need to have, Dr. Ranjani also has said, we need to have good tissues. So many a times when patient has got a large effusion, when they are not very stable, we are in a hurry to close up. So always if we have a frozen on standby to tell us the adequacy of the sample is good, so that the patient does not have to go through an entire procedure of thoracoscopy again, especially if they are sick with an effusion. So I would reiterate the importance of a frozen section in these places.
Right. Thank you. So, so to summarize, so suspect when there is nodularity in the pleura, and as if we suspect when there is a interstitial nodularity nodules in the CT, we suspect sarcoidosis. Similarly, when there is a pleural nodularity, it is very, very important to suspect mesothelioma. And particularly, as Harsh rightly said, when mediastinal pleura is involved. And give off good tissue, not to jump for a medical thoracoscopy. It is better to go for VATS and then get the tissue. And as Dr. Prriya rightly mentioned, please confirm on table. Rapid on-site is very, very important, and get the confirmation of adequacy on the table and then close it. Thank you. And coming to next important question, Dr. Ranjani, can you please enumerate and elaborate how to differentiate between pleural adenocarcinoma and malignant pleural mesothelioma, and various IHCs that you use and molecular markers that you use to diagnose?
First of all, if you don't mind, I'd like to take a couple of minutes. We've had a new WHO release in 2021, and a few interesting new concepts have been elucidated. One is the concept of benign and pre-invasive or in situ mesothelioma. Under benign, we have adenomatoid tumor, and what used to be earlier called well-differentiated papillary mesothelioma is now well-differentiated papillary mesothelial tumor. The most interesting concept is of mesothelioma in situ. This cannot be diagnosed on morphology alone. But right now we have a couple of tests. One is IH immunohistochemistry for loss of BAP1, and the other is actually a FISH for P16 ink, that is CDKN2A. These two tests can help us identify mesothelioma in situ. So even if there's a history of exposure and you have some suspicion, but it hasn't actually grown into a full-blown mesothelioma, then maybe, I mean, it's a bit futuristic, and like somebody pointed out, there could be an increasing incidence of mesothelioma. So if we do pick it up, like with other malignancies, if we can pick it up in the in situ stage, it might be a game changer. So that's the concept of mesothelioma in situ. The other point I wanted to make was we can use pleural fluid for screening as well, again by the use of these two tests. Loss of BAP1 by IHC in cell block of pleural fluid cytology, or molecular testing for P16 ink deletion. So pleural fluid cytology can also be used as a screening test. The third point is nuclear grading in epithelioid mesothelioma. So far, we were not really grading mesotheliomas, and like it's been repeatedly said in this today, this evening, mesothelioma has been kind of a death sentence. But now there is a grading, particularly for epithelioid mesothelioma. We have a low grade and a high grade based on nuclear grade, mitosis, and necrosis. The last point, differentiating between adenocarcinoma and mesothelioma. We have been doing this for a while. Again, a couple of speakers have pointed it out earlier. We usually use a panel. We don't just use one marker. We do 2 or 3 mesothelial markers and 2 or 3 non-mesothelial or carcinoma markers. Calatinin, WT1, CK5/6 are what we've traditionally been using. We also use podoplanin. On the carcinoma side, we use CEA, BERIP4. Also site-specific. Usually it is lung, so we do TTF1. So these are our mesothelioma versus adenocarcinoma markers. For sarcomatoid mesothelioma, podoplanin and GATA3. These are 2 new markers that we are using and which are positive in sarcomatoid mesotheliomas.
Right. And may now take the inputs from Dr. Gaurav and Deepak. Is there any role of EBUS or that FNAC kind of thing, EBUS FNAC or EBUS cell block analysis for diagnosing mesothelioma if there is particularly there is a mediastinal lymph nodes active on PET? Dr. Gaurav, over to you. Unmute, please.
Sir, if the diagnosis of if the PET scan is not clearly positive, and if you are suspecting that there is a lymph node unilateral or a contralateral lymph node spread, then definitely you need to go for an EBUS so that you can really stage the disease and treat it appropriately.
Right. Dr. Harsh, you want to add anything? When do you want to say no for surgical management?
Sir, obviously, if it's a contralateral lymph node, we won't go for surgery. N2 disease is also a very poor prognostic factor. So I would like to refer the patient to Dr. Gaurav for an active EBUS, fast EBUS, to give me results of the mediastinal lymph node staging.
Okay. Coming to again, Gaurav. Yeah, please.
Yeah, can I add on that? The recent ESMO and ESTS guidelines do mention the use of EBUS and also EUS, whether it is EUS or EUSB, for proper staging of malignant mesothelioma. If you are thinking, if the surgeon is thinking that it is a surgical case and you can have a surgical cure, so you have to
any day.
Yeah, subject that patient for a EBUS staging, whether it is PET positive or PET negative. If it's if he's a surgical candidate, he needs to get a complete mediastinal staging done. If EBUS and EUS is not available, then they are also mentioning the use of mediastinoscopy for the same.
Thank you, Deepak. And it is we pulmonologists that who refer patient to either surgeon or medical oncologist or radiation oncologist. What is your take? Whom do you choose first to refer?
Medical oncologist, sir.
Good. Right. What is your take, Deepak?
In any such patients now, I like to have a discussion with all of them. I call them at my office and I have a discussion on a cup of tea whether
Right.
to go for what kind of procedure, and we do staging also together. We also call upon our radiologist, we call upon our pathologist to have a vast discussion once we have a mesothelial
So
tumor.
essentially, you are saying it's a multidisciplinary team decision,
Yes.
not alone. Okay, right. That's good. And Priya, Dr. Priya, you want to add anything here? Whom should I send? Whom the pulmonologists across India to send first?
It should be what Dr. Deepak said. I second. If we ever get a patient of mesothelioma,
Because
it's a combined decision.
let me
It's no
ask you in a
food for all.
different way. See, pulmonologists sitting in probably tertiary care centers like Hyderabad, Delhi, Mumbai. Okay, you have the luxury of sitting and discussing with MDTs. So,
Okay.
if a pulmonologist who's sitting in a two-tier city or at a probably mandal level, okay, whom should they send? What is your take then? Yes, they have a diagnosis. They have sent a tissue sample by doing a thoracoscopy to Dr. Ranjani. Ranjani has declared that this is definitely, damn sure it is malignant mesothelioma. And then whom should this pulmonologist who is sitting in a probably type 2 city to send?
If it's an epithelioid type, to send to me, and if it's a sarcomatoid, to send to medical oncologist.
Fantastic, fantastic. Right. So essentially what entire team is communicating to all of you is, if there is no possibility of MDT, please send to a center where there is an experience of managing mesotheliomas.
Yes.
Okay. Otherwise, if this high-tech, high-pack, these kind of things are impossible to, not in the dreams, not even dreams, they cannot do it. So that's why send to identify a high volume center and then refer across this patient to high volume center. And meanwhile, I would love to take Dr. Deepak to present the overall view of management, medical management, and then current concepts in management of mesothelioma. And Mr. Puneet, please allow Dr. Deepak to share his slides and screen. Dr. Harsh, meanwhile, do you have any surgical videos or something to present?
Sir, I have a surgical picture of a biopsy taken day before. I'll just show you.
Yeah. No. Well, let Dr. Deepak complete his presentation.
Yes, let him.
So we were talking about the overview of mesothelioma
Play this
management.
slide, just play mode so that it will become a bigger one. And yeah, please. That's fantastic.
So actually, if you see in this, so this is the standard therapies what we have, like surgery and if possible combination with chemotherapy or radiotherapy. Then we have radiotherapy, which can be conventional, fractional, or you have IMRT, arc therapy, proton therapy, or chemotherapy, which is mostly cisplatin with a mixed rate. But if you see that other non-specific target-based therapy and surface antigen-dependent therapies, these are also now available, and certain are on their phase 2 and phase 3 trials. If we see there are vaccine therapies where you are seeing autologous DCV, this is dendritic cell vaccine. These all dendritic cell vaccine promotes apoptosis, since it is a very good antigen presenting cell. This will help in treating the mesothelioma. So we have different kind of vaccine therapies. We have ICI therapies, which are immune checkpoint inhibitors therapy. We have anti-CLA4, which is ipilimumab and tremelimumab. We have anti-PD1, PD-L1, where the nivolumab is being used. Then we have a combination strategy also is being under the studies. So basic thing is that for the non-specific target-based therapy, we are actually causing the cell death. So we have oncoviral therapies, we have synthetic lethality therapies like arginine deaminase, ASS1 deficiency. So what it does, it actually upregulates the BAX, which is actually causing the apoptosis of the mesothelial cells, and this is one of the reason why the patient who have been put on these therapies, the mesothelial cells die on its own. That is apoptosis. Then we have angiogenesis inhibitors. We know about bevacizumab, which has been used in lung cancer. It is an anti-VEGF. Then we have cediranib. Nintedanib we have been using as a pulmonologist. We have been using quite frequently in patients of IPF. This is a tyrosine kinase inhibitor which have action against VGFR, PDGFR, and FGFR. Then we have axitinib, sorafenib. These are the modalities which are like non-specific therapies. Then coming to a therapy which is like against the mesothelin. This is the surface antigen dependent therapies. So in this we have the mesothelin cancer vaccine. We have antibodies against this anti-mesothelin, which is actually a surface antigen which is presented by the mesothelioma, in which we have amactizumab with chemotherapy. Then we have anti-mesothelin antibody drug conjugated. Then anti-mesothelin immunotoxin. Then anti-mesothelin CAR-T. CAR is the chimeric antigen receptor therapy. Then we have anti-CAR-T and anti-CD26 monoclonal antibodies. So if we see the overall management, other than the standard therapies, we do have non-specific target therapies, and we have the surface antigen therapies. Most of these therapies are under trial, and they have some of them have shown a good response, while some of them are not showing good response. Mostly this mesothelin, if there is expression of this mesothelin receptor, there is a good response by these agents like mesothelin cancer vaccines and anti-mesothelin antibodies. Till next, they are combining all these therapies, so have to give a patient a complete management for mesothelioma. So this is the overview. Still studies are going on, and there are multiple literature which is available. And even ESMO and ESTS guidelines does mention about all these therapies which are presently available.
Thank you, Dr. Deepak, for such a wonderful presentation. So this gave, very good concept of, apart from standard therapies, what are the other therapies which are in pipeline. And looks like the future is very promising for management of malignant mesothelioma with the various modalities of treatments that are available. So of course, there are a lot of tongue twisters in this, but having said this, okay, the future looks really promising. May I now request Dr. Harsh to share his video of, I request him to guide what are the various important points that we need to follow while taking biopsies of a mesothelioma patient.
Okay, if you can see my screen? No.
No.
Share screen.
Yeah.
You can?
Yes, indeed.
Just a moment. This is how a pic of mesothelioma looks when you enter the thoracic cavity to take a biopsy. So you can see there is lot of nodularity on this surface. This is a diaphragmatic surface. This is a pleural surface. So we have taken a biopsy from this. A good hemostasis have been achieved. So this is one pic I wanted to show of a biopsy taken few days before. And I'll like to show you a small video. This is a video of a PET scan done for the mesothelioma. So you see this nodular pleura, and there is thickening of the mediastinal pleura also, which I was referring to, that if the mediastinal pleura is involved, the suspicion.
Can you please replay the video and then pass it so that our audience will appreciate what is nodular pleural thickening?
Okay.
Yeah. Somewhere behind. Was it?
So you able to see?
Yeah.
See.
Pause it. Yeah. Pause.
These are the mediastinal pleural thickenings which I am talking about.
Yeah,
If there can be thin nodules, there can be thick nodules. I don't have a CT of showing those big nodules also. We randomly usually get those kind of patients also. This was a recent one, so I'm showing you. And last, I would like to show you an sample of how extrapleural pneumonectomy sample looks like. This is an extrapleural pneumonectomy sample where we have taken the whole pleura. You can see the rib impressions on the pleura also. So this is the pleural side of the specimen with the whole lung. And this is the back side of the sample, which shows this is the hilum, this is the pericardium, and this is the diaphragm we have resected with the specimen, and this is the lung which is gone. So this is the extrapleural pneumonectomy specimen I just wanted to show. So basically what people think is that extrapleural pneumonectomy is out of fashion. It should not be done. The complication rates are very high. Theory says like that. But the point is, if you want, what do you want to achieve if you want to do a surgery in a patient of mesothelioma? You want to achieve macroscopic clear margins. And one of the best ways of getting microscopic clear margins is doing an extrapleural pneumonectomy. Now, the point is, most of the thoracic surgeon, and Prriya will agree with me, that the patient should be well prepared for that. He should have the capacity to undergo an extrapleural pneumonectomy. That if that thing is taken care of, the best management still is extrapleural pneumonectomy. You have to do these therapies in a high volume center which are dealing with these diseases very, very frequently. And now the new child, you can say, in town is HITHOC, which is hyperthermic intrathoracic chemotherapy. We are using it in cases of mesothelioma, disseminated thymomas, and now in last two cases we have used it in lung cancer also with the small pleural mets. So the point is, we have to keep in mind that first, a multimodality management of the mesothelioma, where a radiation oncologist, a pulmonologist, a medical oncologist, thoracic surgeon, radiologist, all are present in one room, and they agree over a plan of action. Then you go for tri-modality treatment always. It's chemotherapy followed by surgery, followed by chemotherapy ending, and hemithoracic radiotherapy is the treatment of choice for mesothelioma, which is surgically resectable. So if you want, I can put 2 or 3 lines on HITHOC also.
Please go ahead.
Can I speak something on it? Can I just interrupt?
Yeah, Dr. Prriya, please.
So actually, as per the MARS-1 trial, it has been conclusively proved that you cannot hope to achieve complete microscopic resection in mesothelioma, and what you can achieve is complete macroscopic resection. And that is what MARS trial has actually proved, that the effect of, or the long-term survival of extended pleurectomy is same as an extrapleural pneumonectomy, with much better morbidity and much lesser morbidity and much better quality of life. So even in the MARS-2 trial, in fact, what is coming is now they're actually comparing whether you do an extended pleurectomy also or not. Even that is not needed, or whether that will make a change in the patient's long-term survival or not. So it's not one or two anecdotal, but actually entire trial which has proved that pneumonectomy is now going out of the trend. So even in our earlier study, I think the first out of the 14 patients of last 5 years, the first 5 or 6 were pneumonectomies, but then it has proven that it is equally good, and patients get discharged much faster. They have a much better quality of life and an equal survival. So I think unless the disease is infiltrating the lung extensively, wherein you cannot achieve a complete macroscopic margin also, we should avoid an pneumonectomy.
The problem with India, Prriya, is that you don't get a disease in India where you don't have an infiltration of lung.
We had a lot of patients who we have actually achieved very nicely. Yes. Probably in a better part of the country.
So maybe because we are seeing all the these mesothelioma patients with gross infiltrations of the lung. We don't find only 2 patients we were able to do pleural pneumonectomies, and I'm talking about a data of around 62 patients in the last 12 years. So the point is that I want to make here is that, and you talked about the Mars trial. Mars trial is a very controversial trial. The numbers were very low. 112 was the number. The number in the studies were only 50, and the surgical mortality was much higher. And the primary endpoint was not the survival. So lot of things are there. But let's talk about HITHOC now. So what HITHOC does is it is hyperthermic intrathoracic chemotherapy, wherein what we do is at the end of the surgery, when we completely achieve a macroscopic clear margins, we put two tubes, one going into the base of the lung and base of the thoracic cavity, and other going up in the high apex of the thoracic cavity. These tubes are actually 32 French tubes. We connect these tubes to the cardiopulmonary bypass machine, and the priming solution we use is ringer lactate around 2.5 liter, which we run through the thoracic cavity, achieve a temperature of 41 degrees to 43 degrees. And when this temperature is achieved, we put cisplatin as the agent of our choice in a dosage of 130 to 150 milligrams per meter square body surface area, and then run this fluid for around 1 hour into the thoracic cavity. Now, when we are doing this thing, HITHOC, this is a very specialized thing which should be tried in high volume centers only, because the point is that you have to be very friendly with your anesthetist. At this moment, the patient is very unstable. He's having arrhythmias, lot of
Electrolyte disturbances.
Electrolyte disturbances. Your hemodynamics are going haywire. So you have to concentrate, be friendly, take your anesthetist into consideration, explain the whole process to him, and and after 1 hour you stop the process and disconnect the circuits and just end. Now this HITHOC therapy has a preoperative component also, because the most common complication we face in these HITHOC patients is renal insufficiency in the postoperative period. So you have to have a very good, as Dr. Muthreja already told, that you have to have a very good good ICU backup to do these things. And the other thing is that you have to preoperatively hydrate this patient very well. This is the only condition when I do a pneumonectomy, or our group does a pneumonectomy, and we hydrate the patient in the postoperative period. Otherwise, we keep the patient hypovolemic in the postoperative period. So these are some practical points which has to be taken care. Yes, extrapilar pneumonectomy is going out of fashion, but Priya, I'm assuring you, you're going to get thousands of mesotheliomas in next 10 years, and be prepared to do them. Whatever the modality. Whatever the modality of treatment we are going to
use. It is.
But to cut short down this discussion.
You and me are saying the same thing, just that probably we are getting different kinds of patients.
One more time, I request.
Absolutely.
Okay, I request. Okay, both of you to Priya, particularly Dr. Priya, to elaborate on what is EPP and extended decortication. Okay, for in a layman language, like how a pulmonologist should understand.
So an EPP is extrapleural pneumonectomy. So when we go in for surgery and we plan an extrapleural pneumonectomy for a mesothelioma, when we do the thoracotomy, we ensure that we don't enter the pleural cavity. We remove the entire lung, the parietal pleura, the entire lung, a part of the pericardium, and the diaphragm as a whole. Right. So we don't enter into the pleural cavity at any point, so that we don't sort of invade the malignant place. We don't go through the malignancy at any point. So the entire specimen is removed, as Dr. Harsh had shown, in toto, with the parietal pleura, the entire lung, the pericardium, and the diaphragm. When we do an extended pleurectomy, it is removing the entire parietal and the visceral pleura. So again, we go extrapleural only. At one point, when we have finished through the entire dissection of parietal pleura, we go in, we take out the entire parietal and the visceral pleura, which is the surface on the lung, along with the diaphragm. Right. And if needed, a part of the pericardium, the only thing which is left behind is the lung. That is possible in patients which don't have a completely infiltrative disease, or wherein we have also done a few patients where if it was infiltrating our lung, we have done a lobectomy instead of a pneumonectomy, just to give better, as whatever, that's a different topic. So the extended decortication is the exact same procedure, but we leave the lung behind. We take out the entire pleural cavity and the diaphragm. And in the pneumonectomy part, we take out the pleural cavity and the lung along with diaphragm in toto. This is a difference between these two.
Right. Thank you. So if I understand, whatever Dr. Hush has shown, he has taken off entire lung, and he made sure while he taking off the lung, okay, he has not even touched the parietal pleura. He has gone beyond the, outside the parietal pleural layer, and then he has taken off the entire lung, including diaphragm,
Yes.
and then kept it up. And whereas
Yes.
in case of extended decortication or pleurectomy, they take
That's
off,
what we had
they don't
shown.
take off the lung, but they take off entire pleura, and as they rightly mentioned, macroscopically visible disease, whatever the nodule, whatever the disease extent that is macroscopically visible, that they want to clear it up and make sure that entire pleura, including the mediastinal pleura and diaphragm also,
And the
will
diaphragm.
be taken off in the
So-
extended pleurectomy.
Like I had
Yes.
shown in my presentation of my
Yes.
intraoperative picture of the entire pleura removed, just like with the entire in toto,
Yep.
but not the lung, and the diaphragm also has been removed.
Right. So here, I think Dr. Ranjani, I would like to pitch in Dr. Ranjani here for Dr. Gargi Maitra from Gurugram has asked, what is the presentation and management of benign mesothelioma? Can you please help? I think probably Dr. Gaurav, Dr. Deepak, and Dr. Ranjani can answer this. Doctor.
We commonly see well-differentiated papillary mesothelioma in young women in the peritoneum. It's
Okay.
less common in the pleural space. We do see, I think if they are reasonably localized, they can be resected.
Okay.
Adenomatoid tumor, of course, is absolutely benign. It occurs usually in the uterus or in the paratesticular tissue. Those also can be resected. As for mesothelioma in situ, it's still a controversial entity, and there is no treatment as far as I know at the moment, and they only recommend follow-up.
Okay. It doesn't have any chances that it can transform into malignant mesothelioma.
No, there is a very high incidence of progression,
Okay.
but there is no recommended treatment. In fact, there is however a long latency period between the diagnosis of mesothelioma in situ and development of invasive mesothelioma.
Okay.
There is a median period of at least 60 months in most studies.
So how to
But never
differentiate
really recommend-
both of these by evaluation of pleural fluid? Is there any chance that that's also the follow-up question from Dr. Gargi Maitra?
Yeah.
Okay. By looking at the pleural fluid, can you differentiate between benign mesothelioma and the malignant mesothelioma?
Between benign and malignant, yes. If it's frankly malignant invasive mesothelioma, that we can pick up by picking up loss of BAPN biopsy or P16 ink by fish. In situ mesothelioma can only be diagnosed by biopsy because that's defined by an absence of invasion. So that we cannot pick up on cytology. Even if you do get BAP1 negative cells on cytology, we still have to do a biopsy to assess whether it is in situ or invasive.
Right. Thank you. Anything before concluding this session? So I would request Dr. Hush to give his final comments.
The final comments are, sir, while seeing a patient of pleural disease like empyema or something, keep a very high index of suspicion if the patient is a high-risk group, as told by Dr. Deepak and Dr. Gaurav. And the multimodality treatment of mesothelioma should always be in mind. It is not a single person. You should refer the patient. The whole team of your pulmonologist, radiation oncology, medical oncology should sit on table and decide it. And mesothelioma is a disease which should only be treated by groups who are treating this disease in good numbers, because it's a difficult surgery, it's a difficult treatment, it is a altogether different paradigm of treatment, so it should be treated by experts only. Thank you.
Right. Dr. Prriya, your take-home points?
Very much similar, a very high index of suspicion, just like in lung cancer, we do mistake it with tuberculosis. Similarly for mesothelioma, more so because it's a pleural disease. So very high index of suspicion. And a shout out to all the chest physicians and the surgeons and the physicians, general practitioners, not to consider every pleural disease as a tuberculosis, as you had rightly mentioned, even though the ADA levels are, they are just borderline and not to be considered completely. And it should be done in a high volume center where all the infrastructure is available, starting from a good ICU backup, a good anesthesiologist, very important, a good surgical and a medical oncology team. So that is, I think, a gist of everything of mesothelioma.
Dr. Ranjani?
I think my points are principally that, we can diagnose it on cytology. So even if, at least for the initial diagnosis, in centers which cannot maybe do invasive procedures, cytology would be a good screening test. So if there is any index of suspicion that maybe this is not TB, then maybe we should resort to special tests on cytology.
Thank you. Dr. Gaurav?
So same need to have a very high index of suspicion, and all pleural effusions need to reach to a diagnosis before starting the respective treatments.
Right. Dr. Deepak?
Yeah, so the same thing. I'll back on that. It should be a multidisciplinary approach once you are suspecting that it is a mesothelioma or any pleural adenocarcinoma, even or any pleural malignancy. It should be like, should have a high index of suspicion. Should not consider every pleural effusion, exudative pleural effusion as malignancy, and to do a biopsy, get a confirmed diagnosis, and discuss among your peers that how should you go ahead with the treatment and all.
Thank you. Can you please share the last slide once that you have shared, so that I can draw some conclusion points? My dear friends, so far the logins for this webinar is close to 800 and beyond. That's a fantastic achievement by CCI. And we had seen the lovely discussion with eminent surgeons, pulmonologists, and the pathologists. And here I would like to conclude. First of all, please respect pleural effusion. Any exudative effusion, respect it. Unless you have a diagnosis, do not venture into treat it. Have a diagnosis, confirm the diagnosis, and then start treatment. High risk of high level of suspicion is very, very important to diagnose malignant mesothelioma. Otherwise, you may end up in managing it as a pleural adenocarcinoma or any other malignant pleural effusion. And exposed to asbestosis, as we see in occupations like shipbuilding people, ceramic industry. Okay, these are the points where we need to consider, and history plays a very, very important role in drawing conclusion or considering differential of mesothelioma. So history taking is very important. On radiological evaluation, nodular pleural thickening is very, very important factor in drawing a diagnosis, particularly when there is a mediastinal pleural nodularity is there. And as Dr. Ranjani clearly mentioned, the guidelines or histopathological guidelines have changed in the recent past. As per 2021, there is a benign mesothelioma entity, there is a mesothelioma in situ entity, and there is a malignant mesothelioma entity. We need to differentiate that with appropriate IHCs and then molecular marker studies. And mediastinal staging is very, very crucial when you want to take these patients for operating. So EBUS or EUS guided FNAC is very, very important. And our friend, for the past 2.5 years, we have all used left and right nintedanib in managing COVID pulmonary fibrosis. Although it is not a standard of practice, it is a triple tyrosine kinase inhibitor, and it has got its own adjunctive role in management of malignant mesothelioma. And in coming to surgical chemotherapy options, the principal line of management is using cisplatin and pemetrexate combination modality of management, and particularly when the same chemotherapy they want to use intraoperatively, what we call it to say high-tox or a high-PEC. So cisplatin based chemotherapy agent is used. For surgical management, it is very, very important to refer to high volume centers where they have got extensive expertise in management of mesotheliomas, because extrapleural pneumonectomies and extended decortications can only performed by such areas where there is an extensive critical care backup and experience in managing such cases. And with this, I would like to conclude. I sincerely thank all my expert panelists, Dr. Prriya, Dr. Harsh, Dr. Gaurav, Dr. Deepak, and Dr. Ranjani for sharing their extensive and exhaustive knowledge on this platform for CCI audience. Thank you, CCI audience, for joining, and looking forward to meet you in the next webinar next Thursday. Next week Thursday at 8 p.m. sharp. And sincerely thank Cipla for their unconditional support and our webinar technical support, Mr. Vinod, Mr. Amit, Mr. Vipul, and Mr. Puneet. Thank you so much. Have a lovely weekend. Thank you. I'm sorry. Have a lovely evening.
Thank you so much.
Thank you, sir.
Thank you so
Thanks
much.
a lot, sir. Thanks a lot.
Thank you.
Pleasure.